It gives me great honor to introduce our third speaker, Professor John Somauroo. Okay, Professor Somauroo is the consultant cardiologist with acute cardiology beds at Countess of Chester NHS Trust Hospital, UK. He is the lead cardiologist for heart failure cardiomyopathy clinics in Chester and the Liverpool Heart and Chest Hospital. He is on the Premiership Football Cardiac Screening Panel and is cardiologist to Liverpool Football Club. He was on the Rugby Union Cardiac Screening Panel at Twickenham, London, prior to the 2011 Rugby World Cup. Professor John Somauroo is Honorary Professor in Sports and Exercise Medicine at Liverpool John Moores University and has a large research database screening athletes from many other sports around the world, including Nigerian Olympic team, ultra-endurance runners, boxers, British Aikido martial art team, ice hockey, and rugby league. He is researching cardiac adaptation between different sports, different ethnic groups, males and females, and also the acute and chronic adaptation of the right ventricle following exercise, focusing on detailed ECG and echocardiographic changes. So today, Professor John Somauroo is going to talk about sudden death in athletes and cardiac screening with ECG. Thank you.
Thank you very much for the kind invitation to talk to you today, and for the fantastic reception that myself and my colleagues have received and coming here to Hong Kong. So the aim of today is really to talk about pre-participation screening. We've had a couple of excellent lectures talking about physiology and pathology of sudden cardiac death. And what I'd really like to talk to today is about this screening process. Now, this all came about because of a meeting in London at the European Society of Cardiology by these eminent young chaps here. And what we discussed was putting together this program and really focusing on athletes, as you've started to see here today, and really trying to make sure that these athletes are safe during their sports. We've heard an excellent lecture from Keith George, again talking about how the heart can change, how you get these changes in wall thicknesses, how you can have changes in the dimensions of the heart. And also we've touched a little bit on cardiomyopathies. And we've seen that 1 in 3 athletes who die suddenly die of hypertrophic cardiomyopathy. And if we look at this here on the left-hand side, you can see that the left ventricle can thicken quite considerably in patients with hypertrophic cardiomyopathy. Equally, we can have athletes dying from a dilated cardiomyopathy, and here we'll have some thin-walled hearts with increased left ventricular dimensions and poor left ventricular function. We can have athletes dying of arrhythmogenic right ventricular cardiomyopathy with fibrofatty replacement of predominantly the right ventricle, but some can involve the left ventricle as well. And some more rarer cases we can see of left ventricular non-compaction, which can mirror hypertrabeculation in black athletes. And again, we've touched on the difference between the physiology and the pathology, looking at athletes who may well have wall thicknesses, especially black athletes. 18% can have wall thicknesses between 13 to 18 millimeters versus white athletes. These are physiological changes, whereas wall thicknesses 13 to 16 millimeters can also be seen in some phenotypes of hypertrophic cardiomyopathy. So therefore, this 12 to 16 millimeters is viewed as a grey zone where we're not sure whether it's actually true pathology or extreme physiology. And again, we've touched on some of the conditions before. The hypertrophic cardiomyopathy is quite a common condition. 1 in 500 of the population have hypertrophic cardiomyopathy, and they have myocardial disarray, and again, the increased thickness of the walls. But looking at the ECG, 95% have an abnormal ECG, and this is a gross example here of this deep T-wave inversion across the anterior leads, often seen in apical hypertrophic cardiomyopathy. And when we're trying to differentiate, and Keith talked about this earlier on, we're trying to differentiate between the physiology and pathology. We have this grey zone, and if we try and break down the different ways of differentiating the two, we tend to find that the hypertrophic cardiomyopathy patients tend to have smaller left ventricular cavities, they have larger left atria, bizarre ECG patterns, abnormal left ventricular filling, and a family history of hypertrophic cardiomyopathy is often the case. They often have unusual patterns of left ventricular hypertrophy as well. And one of the other conditions that was touched on was arrhythmogenic right ventricular cardiomyopathy. And again, this is inherited. There's often a family history of sudden cardiac death if you take a good history. And these tend to be exercise-induced. And importantly, 82% have a history of syncope, ECG changes, and/or ventricular arrhythmias. And the ECGs are commonly abnormal as well. And up to 87% have some T-wave inversion beyond V1 on the ECG. The echocardiogram and often the cardiac MR may well show some of the dilatation of the right ventricle and again that fibrofatty replacement with aneurysms and fibrosis. But this is actually a difficult condition to diagnose. So again, this has been touched on before, and I'll briefly just cover this. 91% of athletes who unfortunately die suffer from a ventricular arrhythmia, and the others, sort of 8% of asystole and other arrhythmias, and 1 to 3 per 100,000 per year, predominantly males more than females, mean age of 23, 40% below the age of 18. And this is a low prevalence, but obviously has a profound effect on the family, the team, and unfortunately is often quite high profile. And usually these tend to occur during or just after exercise. Sports aren't the cause. Sports are good for you. But what is important is that these unfortunately trigger this underlying cardiac disease. And this is obviously seen in the case of Fabrice Muamba in a Tottenham Hotspur versus Bolton game. And Fabrice Muamba was screened 4 times. And he was told that he had normal physiological changes. And then unfortunately, this happened. Now, I'm not saying that we can always identify some of these conditions. And in this case, he was lucky because of pitch-side defibrillation. He was cardioverted eventually back to sinus rhythm. And he's alive and well today. Unfortunately, this chap here, Mark Vivian Foe, he died suddenly at a Confederations Cup game. There was no pitch-side defibrillation, and he unfortunately died. And if you do offer pitch-side defibrillation, the chance of survival within 1 minute of defibrillation is 90%, dropping to only 10% by 9 minutes. And again, this has been covered earlier on. Hypertrophic cardiomyopathy throughout most of the world is the commonest cause of sudden cardiac death at around 36%, with a few other cases which may well still be HCM. And around 4% is arrhythmogenic right ventricular cardiomyopathy. Now in Italy, it's actually different. In Italy, hypertrophic cardiomyopathy is the cause of death in only 2%, whereas ARVC is 24%. So there's this great discrepancy between different countries, and predominantly most of Europe and the Western world tend to have these sort of numbers, and Italy stands out as being different. And the main reason for that is because of their pre-participation screening program. And this has been in place since around 1980, and what we find is that the unscreened non-athletic population in Italy, the incidence of sudden cardiac death is around 0.8 per 100,000 per year. And if you play sports, that unfortunately increases your risk. And here it will be 3.6 per 100,000 per year. But by offering a screening program, you can reduce that risk by 89% down to 0.4 per 100,000 per year. And there's also a reduction in deaths from cardiomyopathies. The Americans disagree. They don't have an ECG-based pre-participation screening program. They have a questionnaire and examination. They don't offer ECG, and they say that their data is different, but unfortunately their data doesn't really hold up. It's not relying on a prospective study. They rely on what's published on the internet as gathering their data. So the important thing here is the use of an ECG, and we ran through how to place the leads appropriately on an ECG, on a person to do an ECG yesterday, and it is important to put them in the correct place in order to obtain a correct ECG. Because if you have certain changes on the ECG, you want to make sure that those changes are true to the athlete and not due to incorrect lead positioning. And what we found is that there are different ECG changes between athletes and those with pathological conditions. So the common ECG abnormalities, what we call group 1 changes, are seen in 80% of athletes, and these are commonly sinus bradycardia, first-degree AV block, that's above 200 milliseconds, and that can go up 300, 320, even up to 400 milliseconds, and above 400 is viewed as is more likely to be uncommon and pathological. You can get incomplete right bundle branch block. You can have widespread ST elevation. and isolated voltage criteria for LVH without left axis deviation, without ST depression. And these are all features that are commonly seen in athletes, and we feel that these do not require further investigation. And indeed, you do not need to go on and do an echocardiogram if an athlete undergoes a pre-participation screening questionnaire, has a brief examination, has the ECG performed, and it shows these changes. You do not need to then go on and have the echocardiogram. So these are not associated with cardiac abnormalities and are very common. On the other side of the coin, the group 2 changes are more uncommon and seen in less than 5% of athletes, such as left atrial enlargement, that's P-wave inversion of more than 1 millimeter in V1, any ST depression, we never see that in athletes, pathological Q waves, inverted T waves, and we'll talk about inverted T waves in a minute, complete bundle branch block, and we'll talk about the difference between left and right in a minute, axis deviation, long and short QT, Brugada-like changes, and more than 2 ventricular ectopics on an ECG. These are uncommonly seen in athletes and are viewed as potentially a source of a cardiomyopathy. And these require further evaluation. Now, that was the original data that was published by Corrado and adopted by the European Society of Cardiology in 2010. That's been updated more recently, and this is the Seattle criteria, and it's relatively similar. There are some changes in here, which I'm not going to go over in detail, but one of the major changes is that the early data that the Italians were using didn't incorporate black athletes. And the Seattle criteria focused on black athletes, and it showed that if you have convex, this domed ST elevation preceding T-wave inversion in V1 to V4, if that's in a black athlete, that may well be a normal variant. If it's in a white athlete, it's more likely to be abnormal. So when we see this ECG, and there are some chaps here doing angioplasty who will be looking at this, wondering whether this guy is going to go and have primary angioplasty, this is a normal ECG in a black athlete. This does not require further investigation. This does not even require an echocardiogram. And it's important to differentiate this ST elevation preceding T-wave inversion V1 to V4, but not in other leads, and importantly, not in the inferior leads, not in the lateral leads, just isolated V1 to V4 with the ST elevation. This is a normal variant. So the data has been adopted, and then we've had a change with the refined criteria as well. Again, I'm not going to focus on this too much here. I'm just going to come up with a final overview. But this basically looks at differentiating between those that are deemed to be normal physiological changes, those likely to be pathological, and this sort of group in the middle where if you have them in isolation, then it may well be normal, but more than one is likely to be abnormal. So the different criteria that have been used since 2010 have been the European Society of Cardiology recommendations, the Seattle criteria, and more recently the refined criteria. And the important thing to notice here is that the percentage of positive ECGs for those white athletes has dropped, black athletes has significantly dropped, but importantly, those with hypertrophic cardiomyopathy have all been picked up. Well, nearly all have been picked up, which is important. So the sensitivity and specificity has improved with this new refined criteria. So this is the refined criteria. And this is going to be the international ECG consensus standards. It was supposed to be published last year, be published this year, and this is where we'll now be going in the future with pre-participation screening with ECG. And again, it's got similar changes to those group 1 changes that we saw before, but it's got the additional change of the T-wave inversion, where T-wave inversion, ST elevation preceding T-wave inversion V1 to V4 in black athletes is viewed as a normal variant. T-wave inversion in V1 to V3 under the age of 16 is viewed as a normal variant. And also these borderline changes, if you have these in isolation, no further evaluation is required, but if there's 2 of these, then further evaluation. And also some changes, again, the PR interval being even longer, etc. So is this a normal or an abnormal ECG? Well, looking at the ECG here, we can see that there's a sinus bradycardia of 47. We can see a PR interval of 220 milliseconds. We can see some ST elevation in the high lateral and the lateral leads here. No significant T-wave inversion, no Q waves. This is a normal ECG for an athlete. This one, which you've already seen, shows significant T-wave inversion with these features suggestive of an apical hypertrophic cardiomyopathy. these deep T-wave inversions without the ST elevation preceding, and not confined to V1 to V4, but extending into the lateral and the high lateral leads. This is an abnormal ECG. Okay, so it's not this normal variance here. This is more likely to be an abnormal ECG. And again, this is a slight difference that we use here, where we actually run through the different changes. T-wave inversion V1 to V2 and all is normal. V1 to V3 less than 16 is normal. As I said before, this V1 to V4 with ST elevation is also normal. But importantly, the abnormal changes here. T-wave inversion greater than a millimeter in 2 leads, V2 to V6, 2 in AVF or 1 in AVL. So it's important to actually differentiate where those changes are with T-wave inversion. This is abnormal. And we can see repolarization changes in athletes. This is the so-called peaked and tall T-waves, commonly seen in Caucasian athletes. Again, this is a normal variant. This is the black athlete that we saw before. In fact, those changes seen in black athletes can be in 25%. It's really quite common. So this is a healthy black athlete, whereas ARVC looks very similar. T-wave inversion here, V1, V3, and some biphasic in V4, but without the ST elevation preceding it. So in fact, the worse it looks with ST elevation, the more normal it is in a black athlete. But there are no Q waves here, normal axis, etc. So axis changes, we can see axis changes here. This is minus 43 degrees axis change. So this is viewed as potentially abnormal in isolation. If it's in isolation, no further evaluation is required. Whereas this one here, left atrial enlargement with P-wave inversion of more than a millimeter in V1. Again, in isolation, it's a borderline change, no further evaluation. But if those two were together, there'd be 2 here, then further evaluation. So it's much more specific now about certain ECG changes. ST depression, we never see ST depression on an athlete's ECG. If you ever see ST depression, in this case with T-wave inversion, then it's viewed as potentially abnormal. You get ST depression here. And again, we talked about these ST changes, and this is after one of the athletes that we screened before and after running 50 miles, 14 and a half hours, and he had significant ST elevation with these very peaked and tall T-waves. And again, this is probably a normal variance here. We're not sure what his potassium was at the end of the race, but this is viewed as normal because he's got these changes at baseline as well. Now, complete right bundle branch block. Again, this is right bundle branch block here. The QRS just measures 120 milliseconds. And again, it's one of those criteria in the middle here. In isolation, no further evaluation is required. Whereas left bundle branch block on the ECG, this is obviously left bundle branch block here, this is viewed as an abnormal finding. So we're now differentiating between the different bundle branches. This one here is suggestive here of Wolff-Parkinson-White syndrome, or there's a Wolff-Parkinson-White change on an ECG here. And again, this is potentially viewed as abnormal with some ventricular pre-excitation and would require further investigation. Long QT, well, this is one of our athletes who at baseline had a QT around 465 and post-race nearing 500 milliseconds. And again, long QT is viewed as a potentially abnormal finding here. And if we sort of bear down and look closer at the actual studies, they suggest 470 in male, 480 in female, which is actually longer than we normally use in normal clinical practice. Athletes tend to have that. It's basically based on the fact we're using Bazit's formula, and we probably should be using other formulae, but we're using Bazit's, which is erroneous in athletes because they have this sinus bradycardia. So we allow this to be a little bit longer. So is pre-participation screening useful? Okay, so there are 100,000 athletes in this overview by André Lagerche in 2013, and what was found is that 99,500 were fit to play after the ECG, plus or minus some requiring echo, cardiac MR, and other tests, and only 0.3% were picked up as actually having definitive or probable pathology. So a very small number were picked up. And the way that the screening is now done is a family and personal history, a brief physical examination, and a 12-lead ECG. So talking about the family and personal history, there are certain questions, which I'm not going to go through in detail, but certain questions about chest pain on exertion, breathlessness, dizziness, blackouts, family history of sudden cardiac death, etc. So going through those questions, and if the questions, in the questionnaire there's nothing there that's worrying, if the ECG has some group 1 changes, then the athlete is eligible for competition and does not require further evaluation, does not require an echocardiogram. If there is anything that shows up on the history, or there is some group 2 changes, which is seen in this group here around 10%, then they may well require a further investigation, which may be an echocardiogram, which Dave will touch on after me, and may go on to have further investigations with exercise testing, Holter monitoring, cardiac MR, etc. But the echocardiogram often is the end step to say that the athlete can continue pre-participation, screening is okay and can continue playing. So importantly, what we see here is that there are common ECG changes in 80% of athletes due to this cardiac adaptation, and providing there's no positive family history, there are no symptoms, no abnormal physical findings, and the athlete can participate. You can see some of these ECG changes, and there is an increased risk of sudden death, and then the athlete requires further investigation. So we adopted this sort of protocol for the RFU screening before the 2011 World Cup. And what we found is that in the 606 athletes that we looked at, 92.6% were cleared with the initial evaluation. There was 34 were cleared after the transthoracic echocardiogram, and the false positive rate was around sort of 5.6% here. But then only 1.8% went on to have further assessments. Eventually, none were disqualified from sports. And as far as I know, there have been no athletes from the RFU who've had a sudden cardiac death. Again, a similar protocol has been adopted by football, but UEFA guidelines are slightly different. In UEFA guidelines, they actually mandate that as of August 2008, every player who's in the first squad of a team should have minimum 1 ECG and 1 echocardiogram in their records. And they should be before the 21st birthday. But in the interim, if they were to get any symptoms, they should report that and be further investigated. And the FA screening program is quite succinct in the fact that if you do find some abnormality, it must actually go through the expert committee. We don't just do this outright, one person saying you should stop playing. We go through the committee, which actually also covers you from a legal point of view as well. And a single screen at the age of 16 may also not be adequate, as we do see some conditions like hypertrophic cardiomyopathy do actually show up later in life. And so, after the age of 16, you may need to have further screening. So what we say is that you should be tested again at the ages of 18 and the age of 20 as well. And importantly, if we do find abnormal T-wave inversion, but there's no evidence of cardiomyopathy on the initial echo, they should be tested annually, not every 2 years. They may well require further investigations annually as well. So, ECG is very useful from what we've seen. It can differentiate between pathology and physiology. The important thing is that misinterpretation of the ECG by non-experienced physicians can obviously have serious consequences. So, the incidence of sudden cardiac death is low. The prevalence is around 0.3%, therefore is a low pickup rate, and the relative risk of exercise does increase the risk of sudden death threefold. Average age 23, but again 40%, quite a young age, below 18. Males to females 9-1, so should we actually be screening females? Low incidence. Ethnicity obviously has a great part to play here, and again we don't know what it's like in the Asian population, because most of its data has been collected in Caucasian athletes, but more recently extended into black athletes. America versus Europe, well, the Americans don't use ECG screening. They just, as I said before, use the questionnaire and the examination. Deaths are uncommon. There's a diverse pathology. So is it cost effective to screen? These are highly visible events, unfortunately, like you saw with Fabrice Mwamba. There are numerous, loss of numerous life years, there is a clear relationship between exercise and sudden cardiac death, so we shouldn't really ignore it. And there are interventions to prevent fatalities, as with hypertrophic cardiomyopathy or ARVC with defibrillators, but it may well stop the athlete's career. Again, differentiating between America and Europe, the evaluation with the use of an ECG does increase the cost, there's no doubt about it, and increase the false positive rate as well. But if you exclude ECGs, you pick up only a maximum of 25% of athletes who have underlying conditions. So I don't feel that you are actually offering the athlete the best way to screen them by excluding the ECG. And Barry Marin's data showed that 53 athletes who'd had an ECG, who unfortunately went on to die, well, there was abnormalities seen in 96% of those ECGs. So maybe that should have been acted upon. Again, is it cost effective? Well, Corrado's data, 7% false positive rate, but it's now down to 0.3% by the change in the criteria, from the European criteria to the Seattle criteria, and now the refined criteria. This is obviously important financially and psychologically for athletes while they're awaiting further investigation. We also need to avoid the false negatives, that false reassurance that we're saying to athletes, you are fit and well, go and play, and Fabrice Muamba had his aborted sudden cardiac arrest. And there's only one long-term study. The Italian study is one long-term study, and that's adopted by the Pro Screening Group, so it's difficult to get this balanced view. History examination ECG, well, between 35 to 100 English pounds, depending on numbers. If you add in the ECG and the echo, 250 to 400 pounds. And then if you identify a problem and you go on to have further investigations, such as cardiac MR, you could be adding another £1,000. So you must have this expertise in interpreting the ECG findings, so you don't need to go on and have further investigations. So that black athlete didn't require an echocardiogram because that ECG is normal, didn't need to go and have a cardiac MR, exercise testing, a 24-hour tape, which would have added cost. And you need to have that infrastructure. We talked about this yesterday over dinner. You need an infrastructure. You can't just say to an athlete, well, there is a problem, you need to have investigations, come back in 6 months. The athlete is in limbo and potentially at risk of a sudden cardiac death in that time. So we try and turn things around within a couple of weeks. And coming to the end here, so the ultimate decision to apply either strategy, the American strategy without the ECG, or the European strategy, was driven by speculations and personal opinions. We've only got one long-term study here. But I think the bulk of evidence does actually show that some screening is better than none at all, and I think ECG is very useful. And we must make sure we don't give false reassurance or exclude those athletes who have a pathological change. We should have further studies, but can we really wait that long? So we've seen in America and the rest of the world, it's hypertrophic cardiomyopathy, 36%, drops to only a few percent in Italy. They have an increase in ARVC because that's a proportion that die of that condition. It's a percentage increase, not numbers increase. We've seen this significant reduction. Now, 1 to 3 per 100,000 deaths per year. In the United Kingdom, works out at 12 deaths per week. So it's actually higher than you think. So in summary, screening with a questionnaire, ECG and echocardiogram, if indicated, probably saves lives and is cost effective. It should be done by a sports cardiologist, someone who can read the ECG. And once you've actually identified a problem, you should have an MDT meeting, a multidisciplinary team meeting. You should have electrophysiologists, cardiac MR specialists involved if you need to go on and have those tests. But you may well not need to if the ECG interpretation is correct. Now, importantly, on the legal issue, the Medical Defence Union and the Medical Protection Society in the United Kingdom, they do not provide medical cover, which is why there's only a few sports cardiologists now in the United Kingdom. Everyone else has backed off because they're worried about being sued following a legal case where one of the cardiologists and the FA was sued £10 million. There's an organisation called Sempris which actually do provide that legal cover. And importantly, we have panel discussions. We don't go out on a limb individually, we have panel discussions. Research is vital to reduce false positives and negatives in the future as well. Thank you very much.